Healthcare can be quite slow, and that is for a reason. The stakes are high, the regulation is heavy, and there is zero margin for error. But change is afoot, luckily. In one pilot, AI helped doctors become twice as accurate at diagnosing early heart failure. And so let me repeat that. AI in healthcare can mean that you or your close ones are twice as likely to survive a major medical condition. So that pilot happened at Mayo Clinic, and we're so lucky and excited to have Zachi Attia, Mayo's Clinic co-director of AI, with us on stage today. He's a physician and data scientist leading efforts to bring AI into practice at Mayo Clinic, one of the most trusted medical institutions in the world. Ed is back on the stage, joining him to talk about what it actually takes to move fast in a system built to move slow. How can AI help us deliver when lives are on the line? Ed, welcome back. Take us away.
Thanks, Maxwell, and welcome, Zaki. I'm really honored as well to have the opportunity to be able to talk to you. And we chatted a little bit before about what you've been doing at the Mayo Clinic. What I thought was interesting, and I'm going to let you introduce yourself in a second, but what I thought was interesting is that you have a PhD in bioinformatics. You have an MBA from MIT, but you're not an MD. So why did the Mayo Clinic bring you on board? What was your mandate when you started there, and why?
So first, thank you very much for inviting me today. Very excited to talk here. And as you mentioned, right, I'm not a physician. I'm an AI scientist by training. I came to Mayo after doing my master's in electrical engineering, and then while being here, I did my PhD in computer science, bioinformatics. And I think that was kind of the reasons they brought me. Mayo has amazing physicians, but they needed a set of skills that they did not have at the time. We're talking about 11 years ago, roughly. And they had very smart, visionary physicians trying to solve problems, and they knew that they need some other skill set to solve them. When I came, it was mostly around developing algorithms to detect diseases. AI was not as widely used as today, right? The term at least, right? We use machine learning, we use very complex algorithms, but we just didn't call it AI, right? We call it maybe machine learning at best. And luckily, the people in Mayo, Dr. Friedman and others, had the vision to understand that if we bring this amazing tool, we can help patients by diagnosing disease faster and easier. And since I came, we started a group in cardiology, and we now have about 12 PhD scientists, and I'm the co-director of AI. Mayo has a very unique structure in which I co-direct with a physician to make sure we are completely aligned on what's best for patients and how we can use the best technologies to do that.
That's so cool. I mean, I'm just like stoked that the Mayo is doing this as a technologist in Silicon Valley who is typically just building a bunch of digital crap that ends up going nowhere. You are actually doing something that's going to change lives. So let's talk about this. Let's talk about this. The model that you build, the AI model that helps patients that helps screen patients for cardiac disease. When you first started this, like what did you have to work with? What was the underlying data that you were using? And talk about the early steps in developing this project and how you found success.
Sure. So when I came, we tried to solve detection of hyperkalemia, which is high potassium level in the blood at patients with kidney disease. And very quickly, we were able to develop algorithms that look at the electrocardiogram or the heart electrical activity. It's a recording that any physician can read and can detect for specific arrhythmias, heart attacks maybe, but that's it roughly. And we said, can machine learning look at it and just by looking at many examples, find other things? And then Dr. Paul Friedman, who's now the chair of cardiology, suggested maybe we can detect heart failure or low ejection fraction, which is basically how strong your heart pump works. We know that physicians cannot do that, but Mayo has literally millions of ECG recordings combined with echocardiograms. So we were able to ask the computer to try and detect something from a different test. So you show it the ECG and you say, what would an echocardiogram say? Now you can ask, well, if you have echocardiogram, why not use those, right? Why do you need electrocardiogram? And the main difference is an ECG or electrocardiogram takes 10 seconds to do, and an echocardiogram takes about an hour and costs about $2,000. ECG can be done by a watch or by mobile form factors. So this will allow us to scale for a disease that affects 2 to 9% of the population in the US.
Amazing. And so, you're a technologist. You're working with doctors who are typically not technology forward. Did you have, did you have problems explaining the technology? I mean, how did you make this collaboration work? Because that's something that oftentimes can be a problem in business.
Yeah, for sure. And in Mayo, I assume we have very unique physicians who are very kind of forward-looking and interested in technology. Not everyone, obviously, but I was very fortunate to work with ones that really understand what's needed. And together with them, we went to other physicians. We presented our work. So one of the things we decided to very early on is to publish everything we're doing in academic papers, manuscript that can be peer reviewed, so other physicians can look at it and kind of understand what we are doing. We presented it in conferences. We started our own AI CME course that we do annually to basically teach others how can you take AI and implement it in the practice.
It's
Because
risky too, though, right? Did you get a lot of pushback from people saying, "Oh, what are you doing? Like, this isn't medicine"? I don't know. I mean, putting yourself out there like that can be difficult.
yeah, so I think the main pushback we got is that at some point we moved from explainable machine learning models where you take ECG factors that everyone know and understand to deep neural networks. Now, the algorithms are there for many, many years, but only with the coming of GPUs and so on, we've started using it. So these models can do amazing stuff, but they do it in a mostly unexplainable way. So it's a black box. And then even when we created this model and it worked very well, every time it was presented, they would ask us, yes, but what is it looking at, right? How can you use something you don't know what
Yeah.
it's doing?
That's Gen AI in a nutshell. I mean, currently, right? But I know this is ML, but what about the regulatory aspect? Like you're working in a world where the FDA, if you wanted to actually get this out into the world, you would have to overcome a lot of hurdles to make that happen. So was that on your mind at the outset, or was that something that you kind of proved efficacy and then moved forward to achieve?
Yeah, so we understand the regulation environment and how, let's say, risk-averse people are, and they should be, right? These are people's life, right? Move fast and break things should not work in healthcare because, when you break stuff, these are people lives.
Yeah.
Yet you should be forward-looking. You should be saying, okay, what can I do that would be safe for the patient, and how can I prove it? And I think it starts with trust. As I mentioned before, right, one of the concerns were it's a black box. So our answer for it was not to try and explain it, which we did for scientific reasons. We were interested, but that wasn't the solution for trust. The solution for trust was validation. When you see dogs in the airport, right? We have no idea how bombs smell like, right? We just teach dogs by showing them examples and testing them. We validate their internal model, right? And then we use them because we trust the process. So we said, can we create a similar process of validation to create enough trust? And with trust, we will build a set of experiments and tests that we need to get to FDA, which we did eventually.
And this was not a trivial task, right? You mentioned to me that you had to prove that this kind of data, this kind of approach worked not just for white people in Minnesota. It had to work globally for all people in order for it to attain that trust and to also get approval, regulatory approval.
Right. And we were very, very focused on making sure our algorithms are fair and efficient and work for everyone. So we started with the basic idea of low ejection fraction detection. We did a retrospective study. Then we did a prospective study. We just checked the algorithm, how it works over time. And then we said, well, we know that the majority of patients in Mayo are white, right? But we want to make sure that the models we are making are useful for everyone. So first you can ask yourself, but you never fed in the race. Why would it matter? You only fed in an ECG. So we tested it, and an ECG can tell your sex, your biological sex, your age, and your race. So even if you don't tell it, it can still use that to make decisions, which can be a good thing or a bad thing.
You can take my ECG and then you can tell me my race from the ECG based on the model.
Yes, and not only that,
Wow.
when it tells you your age, it doesn't always say your chronological age. It sometimes have mistakes. Sometimes you look older, sometimes you look younger. And when we compare the two outcomes, when the AI model thinks you're older, you are more likely to die sooner. If it says that you're younger, it basically tells you that your cardiac health is better. So it's seeing things that we do not see. Again, good things, right? It's a new biomarker of health. We can maybe explore longevity. And if you have anti-aging treatments, maybe we can use that. The other side is maybe it can use things that we didn't plan it to use. So we did a study where we took in our testing set patients by race and ethnicity, self-disclosed, and we compared the outcomes of the model for each of these groups. And we found that for all the groups that we checked, the AUC, or the area under the curve, which we use to measure the outcomes of the model, was as high as for the general population. So the model did work very well for all races and ethnicities. And now it's really important to make sure that people understand that it doesn't mean that if you build an AI model on ECG, you don't have to test it because it works the same. It only means that for the algorithms we developed, it didn't matter. And it actually means that you have to do the exact same test because it can detect your age, race, and sex, right? So if you don't do that test, you're at risk of failing the next stage and getting worse cares to patient based on the race.
Wow. So, okay, so you've proven this thing works, you've done studies, and at some point it comes time for FDA approval, I assume. And so then, how does that go? What any additional hurdles that came up for that? And for the audience here, some of which might be working in regulatory industries, like any advice you can give around how you manage that sort of government regulatory body as someone who is trying to push this through?
Yeah, so we did all of these studies, and then we went to FDA and said, this is the algorithm we created. We did it with a company Mayo spun out called Numana, which took that and went to FDA for a pre-submission, say, what do we need to do to prove you this is working? This was a very new algorithm. So we are trying to do things that humans cannot do. That adds complexity because what do you match it to, right? So we got the requirements for them. And one of the requirements was to show on very diverse populations outside of Mayo Clinic. So we had to go and partner with other hospitals from the coasts, looking at diverse populations geographically, racially, different ages, and report those outcomes. So we did another study, which was semi-prospective. We went to hospitals and captured new data that they're collecting for clinical care anyway, and then we had to go back and show it. Now, this is only to show that the model works well and does what we think it does. You also have to show that there's a low cybersecurity risk to the system. You have to show that we do quality checks. There are many, many steps that you should do. And I really recommend kind of understanding those needs as early as possible. So I would even go and say, we have an idea, we have a proof of concept. Now, if I want to take it to scale, what else do I need to prove? Because maybe you design your studies differently. We were very lucky that our studies kind of worked very well with it. Mayo has a lot of history with doing clinical trials, so it was probably easier. But if you then go to FDA and ask them, for example, what do I need to prove this? You can derive your plan.
So has this product or this tool been put into the hands of actual physicians? Is this out in the world now? Is this being used?
Yeah, that's a great question. So, you know, we got FDA approval about a year and a half ago. In 12 leads, another year with stethoscope, using echo stethoscope. and people are already using it. In the Mayo Clinic, we've created a way to serve these models to physicians. So now any patients coming to Mayo can get an ECG and their physician see on their EMR immediately their AI results. So they can see if they have high probability of low ejection fraction, if they have atrial fibrillation, even though they're in normal sinus rhythm. Do they even have liver disease? We have about 12 different algorithms that it's checking. Many of them are in FDA approval process. There is a waiver that physician can use these tools developed in Mayo, but we have a very rigorous process in the background to approve them. So we do a lot of quality measurements, and all the steps I mentioned for the low EF, we have done for the other algorithms, so prospective studies and etc. It has been used in Mayo more than 800,000 times by clinicians. And some of these models were also used worldwide. So we just had a study by Dr. Adenosware, which went to Nigeria and tested our algorithm on pregnant women. And Nigeria has one of the highest maternal mortality rates, and often it's due to heart disease that women develop cardiomyopathies during pregnancies. So she took our model and applied it to half of the patients. And we saw that when you apply our model using a stethoscope, 15 seconds test, you find double the amount of heart disease that you would find otherwise. So these models are getting to patients not only in Minnesota and in the US, even in rural areas and third world countries.
So and these are places where I would imagine that the healthcare infrastructure, the testing capabilities are not as advanced as we might have in the United States. And so you're giving them a lower bar essentially to be able to do these diagnoses and sort of save lives in that sense.
Yeah, and you know, we think about it, but even Americans, the majority of Americans live more than 50 miles away from an echocardiogram. So having those tools to Apple Watches, to stethoscopes, to clinics, you can imagine you go to the supermarket and like you do a blood pressure, you get an ECG and you get screened, can save lives and help patients.
Okay, I've been hanging out in the chat during today, and it's been amazing. So chat people, you guys are awesome. It's been so awesome to look at the comments and so much wisdom and stuff. But one thing that's come up a lot in there is this idea of change management, right? Like this new technology is coming in, it's doing things. My general practitioner is not at the Mayo Clinic. She is in town, and I've had conversations with her about AI and what it means for medicine. She's skeptical. She's like, yeah, I don't know if I'm ready for that. I have all my training as a medical doctor. I rely on my instincts. I rely on my training, my knowledge, et cetera. And she's, I think a little skeptical of the rush of AI tools, and that's from like her AI scribe to maybe tools like this. So, any thoughts around how you think this might play out, or what doctors will need to see or to experience to accept these tools?
Yeah, so it's a great question, right? As you said, not everyone have the resources and the access to these models. Luckily, physicians want to do the best for their patients, and I think that's globally true. And they also listen to evidence-based medicine. So that's why we are so focused on doing these studies and presenting them in conferences. And we checked if giving physicians access, we didn't tell them you have to use it. We didn't make them order the test if the screen was positive. We just gave them another piece of information to put in their medical context when they see you. And the half of the physicians who had that on more diseases in the same patient population and did not order more testing. So it's also told them who doesn't need further testings. And as we do these things, physicians see these papers, see this in conferences, and understand that this is the way they care for patients. I think every physician, the main thing they care about, right? How can they do to them what we can do and how to do it in the best way. And we partner together to help them help patients. And so I think it's kind of on us to keep educating physicians and giving them more.
I really love that I get to the subject matter. The insights are going to be the kind of work they're doing and the kind of value you can deliver with AI. If it comes too top down, there's not enough any rubber. So the thing that's really interesting to me is what the kind of ethos that you have here, where you are not just putting this out into the world and saying, hey, use it, it's good enough, but you're proving it with studies. You're doing multiple studies, you're doing different kinds of studies to prove efficacy and to kind of engender trust with this audience. Is that something that you knew you were going to have to do ahead of time, or was that something that you learned along the way?
Yeah, I think I was more naive, I would say, when I arrived, right? I said, we'll build something cool, people would use it. But I think the title of this chat is around reluctance and kind of regulated environments, right? I didn't understand the pushback I would get mostly outside of Mayo. Mayo is also kind of a bubble. So I came there, I stayed naive for a long time because physician wants to use it and they try things and they're willing to do studies. And then you go outside and they say, okay, they don't really have the same exposure to the stuff we're doing, right? So in their way of protecting patients, they want to make sure we're only putting things that helping their patients and not wasting their times. Imagine how when you go to your physician, how busy she is, right? How many times, like how much time she needs to spend in front of the computer. We don't want to create more of that, right? We want to clear her to spend more time with you and give her the right tools and access to the newest technologies. So it took me some time, but again, when you apply the same method and say, what are the basic concepts? Providers want to help patients. They are very good at learning from evidence, right? And we need to build it around their needs, right? So we need to integrate it into the clinical process. We put our model in the EMR. We didn't say you have to use now a new tool. We didn't say you have to open a new window, right? Whenever they open the clinic number of that patient, they automatically have access to the data because we don't want to add more clerical burden to their day. So I think once you kind of start understanding it and spending time with physicians, like as I mentioned earlier, I'm actually sharing an office with a cardiologist. So we can chat between cases. We can see, like I can see what he does. Me and the engineers that work with me join cases, meet patients. It allows you to kind of understand what will be needed. How can you smooth out those things that might slow you down in the process of integration?
Where is this going? I mean, what are you working on more things? And if you were to kind of extrapolate into the future a little bit, what does the future of medicine look like for doctors when they have tools like this? I mean, are more things coming? Can we expect this kind of augmentation to be part of the usual process that doctors use to evaluate and examine patients?
So I think those few levels. The first level is automation, right? I think AI would help us automate many of the processes that we don't really need a physician to do today. They just do it because they have to, right? They can just check the box and say, yes, that's what I meant. And, reordering of things, summary of the chat, ambient listening, as you mentioned, right? Instead of scribing everything you say, they can talk to you, look at look to at you while talking to you, and have this done in parallel, right? That's the simplest layer. I think that would help significantly and would be implemented almost immediately. The second part is, can we automate some of the clinical work they're doing? Right, there's models published by Microsoft, models published by others that do what clinicians can do already, right? That's very basic. Again, this will allow them to scale. I still think for the foreseeable future, we would need a human overread on those. So it will save them some time, not completely eliminate that need. And then we're starting to look at tools like the ones we created, where we give physicians the ability to do more than humans can do. So look at an ECG and say what an echo would say. We have projects where we look at the echocardiogram and say, can you say, would you develop a disease in the future, right? So these will add a lot of information to the clinician. Some of it we don't know how it would affect their day-to-day now, right? Because if I'm going to tell you that you're very likely to have heart disease in 5 years, right? We're not sure what to do. We probably want to monitor you, right? We want to warn you, watch your diet, exercise, but it's unclear yet completely, right? These are very, very novel things. And there's also the use of AI to replace some of the interaction that can be done using avatars, for example, right? Can we save your physician time and your time by you chatting with an avatar, right? That's kind of something that we still need to understand better, right? If patients would like it or not, does it save time? Does it get you more of your clinician focus when you do meet them? So we have all of these layers. The last one is more generative AI, the other ones are more machine learning based. Um, and I think all of those will improve patient care, will improve the feeling of physicians because now they can really walk in the top of their license, right? They can talk to the patient, focus on them and not on the non-clinical parts. But some things will take some time.
I know we're going to run out of time here, so I'll just ask a kind of a summarizing question here. Uh, you're a technologist, you're working in a regulated environment, you're working with subject matter experts. For other people in the audience who might be working in regulated environments, whether it's healthcare or banking or something like that, I know those are really different, but maybe some of the same rules can apply. So what advice, what have you learned essentially over the last 10 years in doing this that you can kind of give people as they start, as they're just starting maybe on their AI journey, that something that was hard-won knowledge for you?
Yeah, so I think the main thing I learned is that the sentence kind of if you build it, they will come is not true, right? If you build it and you build it well, it will allow you to start the process. And I think in every regulated environment, you have to go and understand what is needed to comply with those regulations and derive the, let's call it the product, right, from those, right? You want to make sure that in the end, what you're creating now can be used, in our case, by patients, right, or for patients. There's really no reason for us to do research, spend resources on something that will end up not being able to approve for use, right? So it's really important to understand very early on. I assume after the initial proof of concept, right? Because I also don't want to say, oh, only do things that regulations say you can today, because that can change. So if you have a very innovative idea, try it, show that it works. But once it works and you have to create a product out of it, you have to understand the process, you have to talk to the experts. In this case, in our case, physicians, bankers might be bankers or regulatory experts in that, and kind of say, how does this integrate to your work process, to your day-to-day? And let's derive from, in our case, FDA, what do we need to show to prove that it works, right? And then you design the studies, you design the cohorts that you want to work. You might adjust the training set. In our case, it works very well for all races and ethnicity. It might not have, right? So you might have to go back and say, let's go back and retrain the model.
Well, Zachi, I'm grateful for everything that you do. I'm glad that you exist. I'm glad that the Mayo is out there employing you and asking you to innovate and create this new technology and deploy it in ways that are actually genuinely helping the world and literally saving lives. So thank you so much for being here today. I really enjoyed our conversation, and I hope the audience got some inspiration out of this that they can take forward.
Thank you very, very much for inviting me. And again, I see myself as a representative of the whole team. There's a huge team working behind it, spending a lot of time trying to help patients. So I'm really appreciative of everyone in Mayo as well.
Cool. Tell them we said thanks.